Hi, folks. As people join us, I'd like to introduce myself. I'll do it again as we have more folks here. My name is Kabir Cooppan-Boyd, the Marketing and Communications Manager at Fluence. Excited for you all to join us for this webinar on building sustainable psychedelic care practice. We'll be focusing in on ketamine therapy and the ethics of building sustainability in your clinical practice. I'm joined by Dr. Chantelle Thomas. Very excited for the conversation we'll be having. As a reminder, this webinar does offer a 1-hour CE credit, and to claim that CE credit, you'll have to fill out our brief survey. We'd like for those folks interested in receiving the CE credit to do it actually during the live session or directly after, preferably now as soon as you can. There's a link to that in the chat. It's the SurveyMonkey link. And again, to receive the CE credit, you do have to fill that out. We aren't able to grant it retroactively. We'll put a link to that at the end as well. If you have any questions about CEs, again, please feel free to reach out, put a question in the chat as well. We'll get to it at the end. I am based in New York City. Chantelle, please feel free to let folks know where you're joining from.
Well, actually, right now I'm joining from Cape Cod because I'm here for a conference where I'm speaking tomorrow, but hence the lovely hotel background. But I'm based in Madison, Wisconsin. I'm a clinical psychologist there. And yeah, I've had the privilege and opportunity to work with Fluence for several years now and have been working on clinical trials with psychedelics for over 10 years. And was trained in ketamine-assisted psychotherapy in 2019 and have had a practice since 2020 alongside of the psychedelic clinical trial research. And I'm an executive clinical director of a substance abuse and trauma treatment facility based in Wisconsin.
Amazing. Yeah, Thanks for sharing all of that.
Yep.
As a very brief introduction, Kabir, again, I focus on communications and marketing here at Fluence, and I have a background in legislative work related to psychedelic therapy, as well as advocacy and education. So thrilled to be here with you all, and without further ado, we can jump into the topic for today, how to build a psychedelic therapy practice that is sustainable, ethical, and aligned with one's clinical values. So starting off, let's talk about framing and foundations for the general webinar. First question, when you think about a sustainable psychedelic therapy practice, what does that mean to you beyond just financial viability?
Yeah, well, in some ways, that's a little bit of a segue into the nature of what it means to be working with psychedelics and psychedelic-assisted therapy. It's of course you need to be viable as a business or sustainable as a business. But for me, what felt really important in terms of sustainability is having kind of a network of support that was set up for me. I think this is true maybe in therapy in some ways, but I think because this is such a new landscape, there's a lot of times where the decisions that you're making about whether or not to treat someone, whether to retreat someone, whether or not someone's a candidate, it's gray a lot of the time. And, also what's unique if you're working as a mental health provider and you're not the person prescribing, for instance, with ketamine, you're also really thinking about the relationship you establish with the person that's prescribing and whether that's in-house for you or is that someone that you're consulting with in the community and what's the nature of that relationship. And in some instances, it's the doctor that's making that decision. In some instances, you're making a decision. They're trying to advocate with a medical provider to prescribe. So it's not always a physician. It could be a nurse practitioner or a mid-level provider. So you can't just think about yourself in isolation when it comes to ketamine-assisted psychotherapy. You're really thinking about systems of care. And so that's another component of it. How are you going to navigate these gray zone areas? how you make those decisions. And a lot of time people are working with ketamine in an off-label capacity. And so that's another interesting caveat in terms of how you're making decisions, or who will you treat? How often will you treat them? So there's a lot of nuance there. And as a provider, I find in some ways those unclear questions are sometimes the most exciting ones, but they are also ones that sometimes create a lot of anxiety or stress too, because it's not 100% clear what the answer is in that moment, because it's context driven, and it's influenced by the people who are in that decision-making position with you. Does that feel like it
Definitely.
speaks to
Yeah.
it?
No, definitely. And we'll get into scope of practice a lot more later here with more questions, but I appreciate you looping that in. As a follow-up question, I'm curious how you keep your clinical values and ethical commitments as a practitioner at the center of that practice while also balancing those business realities. So you've kind of touched on that to some degree, but really digging into um, the integration of your ethics into decision making. So, for example, your client load, your fee structure, accessibility, and really centering that and avoiding drifting towards a purely revenue driven model. Are there some choices or exercises that might help folks with that, or would you be able to speak to that some?
Mm-hmm. Yeah, I have a lot of compassion for people who have to be in the business lane completely and also in the clinical lane. As maybe a private practice owner, I think you're already holding that tension in some ways as a therapist, let's say. We come into
Mm-hmm.
these decisions sometimes around, should I keep treating this person? Are we really moving the needle with this therapy? Are we doing this as a force of habit? So I think for many clinicians, depending on how you orient, hopefully you're already asking some of these questions about the ethics and the business practice of something. I think what's a little different is there's not clear guidance in the industry about what people should be charging for ketamine assisted psychotherapy. And one piece that I think gets confusing as well is people do a lot of additional training to become a ketamine assisted psychotherapist. And so while it may not look overtly like you're doing something that looks that different in some ways, you have this investment in training. And so then that brings a different kind of expertise, and you're taking on a different risk level when you do ketamine assisted psychotherapy. So all of that somehow needs to be captured in the work that you're doing. The way that I practiced in CAP is very much driven. I use a therapy-based model. It's a ketamine-assisted psychotherapy model. And I think in some ways, ketamine helps me stay really humble about what we can accomplish because you can't really just sell it as a thing that's going to automatically make everything better, because it's too slippery of a medicine for me to be able to like say anything about it. It helps kind of keep us in check. The question, I think, in some ways is, which I think is sometimes not always handled well in environments where you're just relying on the medicine, let's say an infusion clinic that doesn't have any sort of therapeutic component to it, as much as like it's an administration of a medicine, is, how frequently do you just keep treating and treating and treating, even though the needle's not moving? That to me feels like a really clear ethical quandary, right? Especially when the patient's like, let's try it again. Let's try it again. I think when you work with it therapeutically, it's easier to stay close sometimes to the ethical edge of it, because I really think the decision to do CAP needs to be co-created between a provider and a client. And a way to kind of keep ethics at the center of that is the informed consent process for me. It's like, we can't guarantee a lot of things. I have it with ketamine, right? I can say there's a range of what could happen, but in some ways it's going to work within your system in the places it's going to work. And let's see if financially it's viable for you to budget for a certain number of sessions. And let's really talk through the pros and the cons, the risks and the potential benefits. And then let's make this decision together. Because if I feel like I'm steering the decision, I go into that session with so much more pressure on myself that's not helpful for anyone. Um, and it's, working with CAP has been a great exercise in recognizing the limitations of what I can control. And so for me, a really good ethical check is transparency, really thorough informed consent, and knowing that a client understands how to weigh those things, all with a treatment that is defined by unpredictability. So it's like, um, it's really about bringing into the conversation, tolerating uncertainty, and where have we seen things sometimes be really helpful. And our hope is that this will move or that this might shift or soften, but we don't really know until we kind of get inside the system with you and see what that interaction effect is like with the subjective effects in your experience. So, if you work in a really relational way and you carry a lot of transparency in your therapeutic style, I think those conversations get a lot easier. I think for people who tend to be a little bit more of in a certain type of therapy role that does not reveal a lot, I think that's a little trickier. So at least from my vantage point, I'm sure there's other nuances there that I'm not speaking to, but those are some of the things that come to mind for me is how can we work with the nature of this compound in a way that maintains transparency and authenticity. And also kind of what we're doing with a client is we're on this journey of not knowing together. And I don't think it's helpful to lean into a false kind of expertise about what you can predict. And I think that that's sometimes where we might get into trouble with what we want to promise by using it.
Totally. Yeah. Yeah. Makes a lot of sense. I really appreciate your personal experience looped into that answer. That's hopefully very helpful for folks. I'm curious, as you talk about authenticity and relationality as kind of cornerstones to an ethically minded and grounded practice, how does, I suppose, the desire to scale one's practice up and practice for volume versus that depth of care, what are some, trade-offs that might come when folks are choosing to scale up versus keeping a practice small? How might that impact a client's well-being as well as your own as a practitioner?
Yeah, it's such a great question. I'm going to speak in abstraction because, of course, I haven't had the lived experience of scaling this work. I have colleagues and friends who I think, the route of administration that you're using, I think has a big impact on that sometimes too, because, if you work in an infusion clinic setting or infusions or IM, you get a little bit more, it can be a little cleaner, the time on medicine and the time off medicine. I mean, with IV, you literally can turn it off. So you can slot people in more frequent intervals. You've got these other interesting questions about, how do you deal with the fact that people come back differently from medicine? Do you have a second room where people can recover? There's a lot of inherent interesting kind of challenges there, depending on the route of administration that you're working with. But if you're working with a fair amount of therapeutic involvement during the session itself, that's going to kind of limit how much you can stack people in a day. There's also just like the psychological and kind of energetic impact of being in that place of not knowing with someone and kind of following their process and also staying available and grounded and present. It does energetically feel different than therapy that happens primarily in everyday consciousness. Now, depending on what you're working with, right? Like you could ask someone the same question who does EMDR trauma reprocessing. How many trauma reprocessing sessions can you do in a day? And where does that start to have an impact on you as a provider? And what's that threshold? And if you just start doing, that kind of work with all of your clients, you're going to start to see that it's too much for some people. They may not be ready for it. They might need more integration time. I think as we think about scaling and doing more sessions, I think inherently providers might pull back a little bit on their level of involvement that they can have during the session, because it's just like it's a big energetic ask. And so if you're practicing a model that relies more heavy on just the client's experience with the ketamine and less of you as being like a significant component of that process, it's easier to scale. But what someone is experiencing is different then, right? Like they're just getting a safe, ideally a safe container to experience the medicine. I imagine that may not apply to a lot of the folks in this audience necessarily, because if you want to integrate it into your psychotherapy practice, you're going to have you're going to be doing something different there than just providing a container for the medicine, because they can do that in a medical environment. And I think, God, it's like with anything, you learn a new technique or something, and it's like every client all of a sudden becomes a candidate in your head. And I think that's interesting. And is that true that everyone could be a candidate? There may be a way that you're conceptualizing this work that you could see how it could move the needle for people. But again, I do come back to this idea that if you're really paying attention to the nuances and the complexities, trying to scale quickly, especially as you're building your practice, I think people will really feel the impact of that. It's just carrying a higher level of risk, and it's carrying a higher level of uncertainty. And it's also a lot of people that want a result. When you do something interventional like CAP, they want to get something for the money they're investing. And that takes a toll on a provider, I think. I felt that myself. In fact, my worst nightmare is to overpromise or for people to be disappointed in a result, which is like such an interesting edge to be doing psychedelic work, because a lot of psychedelic work is about disappointment. And not because things have gone badly, but just because they've gone off the grid of prediction, which is part of why we think they're so impactful anyways. So really a CAP practice is like, oh, this is a great opportunity to move the needle in a different way, to catalyze something, to disrupt something, to amplify something. But you don't decide to do CAP because you want your practice to be more simple. Like, I don't think that's why people do it. Right. And so I think most clinicians that I know want to take their time building confidence with the medicine themselves. That's what you're doing as a clinician too, right? Like by proxy, you're learning more about how it works for your particular clientele. And I think that takes some time to build up. And I think some people might overshoot and do too many CAP sessions in a week and be like, wow, that was too much for me. I need to scale that back. Or they discover that they're pushing someone to do it a little bit too much. And then they're thinking, okay, maybe I need to like holster this. And that's why I think, again, those really transparent, co-created decision-making can be really important as a safeguard for not just like implementing it across the board for all of your clients.
Totally. Yeah, that makes a lot of sense. I mean, you're really highlighting the complexity of adding this into your practice. And I imagine that as you start to work with other folks, that only grows. So I'm curious if you could speak some to the partnership dynamics that exists in ketamine practice and resolving conflict, finding alignment when it comes to the clinic vision, finances, operations, and really any strategies to improve decision-making and business planning when running a practice with other people involved.
Yeah. I mean, I think, okay, so there's a luxury of being able to have access to people that you can work with that can prescribe or partner with you in that way. I'm talking about from a therapist lens or even from a prescriber lens. So I recognize there are people in rural communities where they're just trying to find someone who's willing to even entertain the conversation, because it's pretty disruptive. So I don't want to be so bold to assume that you have it all at the table and then you can just make certain choices, right? Sometimes you just have to work with what's available. But I do think it is a really interesting edge to ask yourself the question as a provider of ketamine-assisted psychotherapy, for example. How much co-created decision-making do I want to make with the person who's prescribing? And how do I build that relationship in a way that feels mutual and respectful and doesn't leave me feeling like I don't have any decision-making in this process because I'm going to be the one sitting with them and supporting them? And maybe in some ways that just comes down to like personality and relational dynamics in terms of like, how do you engage this prescriber? Or, one of the questions that you might ask, even within your own practice, let's say if you're all under the same roof, is like, how do we want to handle it if we have a difference in opinion of someone who's appropriate and you might feel they're inappropriate? What are the limits of this relationship? Like, is this a space where I could advocate for a client, or in this position as a prescriber, would you prefer that I don't do that? Is there flexibility in us evolving our understanding of who's appropriate? Is this something that I just want to get a clearer sense of that? And those conversations are tricky to have because they're process-based conversations about a relationship. Like, how do we handle conflict? And what if we disagree on something? What is the true power differential here? Are you the ultimate decision maker? Do I get any decision-making power? Those are conversations that are really hard to have, but man, I think they just drastically improve the experience for the client as well as for the provider. Because I mean, think about it. If you advocate for something and the person that's prescribing was not on board and you sense that there's some sort of pressure or tension, and then all of a sudden the client has a really hard time in the session, it is like such a different experience than someone that both of you were on the same page with. Now you have this pressure to somehow make it better for the client, but also because you want to, maintain your respect and your collaboration with this provider. So I think these sneaky like things that we hold as pressures or expectations, if we don't have a collaborative dialogue where we can talk about those things openly, they infiltrate the therapeutic process in ways that I think can be really problematic for therapists and also really problematic for clients. So these conversations aren't just about like getting to the point where you can do the cap. It's like how you get there shows up in the therapy, in my opinion. So I think those are really good things to be thinking about in terms of the transparency of the relationships that you can have and how you might handle conflict or it's been a really interesting edge for therapists in this space too, because I know, therapists, clinicians, or mental health providers across the board of different kind of disciplines or orientations, some folks just stay so far away from conversations about medication and they don't bring that into their therapeutic work. And so this edge of working with ketamine can feel like a Grand Canyon to cross in terms of talking about a drug and drug effects. And for other providers who are more comfortable having interactive conversations around psychotropics, this doesn't feel so far. So these are all things to take into consideration in terms of your regular practice habits. Like how much are you going to lean on the prescriber to have those conversations? How much of them do you feel equipped to be able to navigate yourself while staying within the scope of your practice? I notice a lot of people get really nervous to have conversations that sound medical. And it's like, you're not becoming a provider in that moment. You're just helping someone really weigh information. And you do have expertise as a therapist, as a mental health clinician on how people take information in and how they make decisions. That is an area of expertise. So you can do that with a drug. You can say like, well, what do you know about this? And how would you ask questions about it? And what would be your concerns? And what don't you like about, that process should not just be the domain of medical providers, in my opinion. That should be an area where we as clinicians are able to help people kind of really sort through questions and decisions. We're not giving the expert opinion there. We're just helping them kind of really sit with something and formulate an opinion about it and learn what's at stake. What are expectations are going into this process? Like that's going to have a big impact on the therapy session itself. So I think it's really important not to stay too siloed in what we think is our domain versus another provider's domain. These ketamine-assisted psychotherapy opportunities have really created space for a truly integrated conversation in mental health, which, we don't get a lot of those chances sometimes. So I think it can look really differently depending on how those lines are drawn at the beginning of those relationships.
Amazing. Yeah, that's a perfect segue into talking about scope of practice a little bit more and understanding exactly how different folks might fit into a care team, the role a practitioner would play. I'm curious how you personally would decide which services to offer and which to decline or refer out, kind of digging into the criteria for fit, clients' needs, your own expertise, scope of practice, all of that, and how you might know that a client is someone you don't want to take on and there might be a better opportunity for them. I swear.
Yeah, I'll try and keep track of some of those pieces. You might have to pull me back to them. Well, one very clean area for me in terms of deciding goodness of fit can sometimes come down to financial viability. The version of CAP that I do is a very therapy heavy model. It's a lot of processing in real time. Therapeutically, we're working in the relational range, the relational dosing range. So I'm actually kind of delivering a therapeutic intervention alongside of the ketamine-assisted psychotherapy process. So when I talk with people who are really just wanting an experience with ketamine, and they believe that this could be a compound that could be helpful to them, and they're not so invested in the therapeutic opportunity that's presented with ketamine, that feels a little clearer, because if they want just a pure experience with ketamine, and in some ways, they actually are leaning towards a more passive treatment model. They want ketamine to happen to them, and they don't see it as a relationship that they're developing, an interaction effect with their interior and the subjective effects of the medicine. Then I will often encourage people to perhaps a pure infusion model. Also, sometimes where the depression is so severe that I really do feel like they might benefit from multiple treatments in a row, kind of in succession. They're not even really available for therapeutic work because whatever's happening is kind of put them in a freeze state. So those are folks I might refer out. People who aren't really invested in the therapeutic component, I feel ethically like it's a bit of a problem for me to try and kind of convince them that therapy is an important part of the equation when they're really just wanting an opportunity to experience ketamine. And I'm not talking recreationally. I'm saying even people are really suffering and just think ketamine could be a real avenue for them. So for me, it's been an interesting process kind of in determining candidacy, because I don't have an outpatient practice that then I'm implementing CAP with my outpatient practice. People are coming to me specifically for CAP. That's the model that I'm using. So that gives me a little bit more flexibility in being able to say, is the way that I deliver it with the approach that I use, and let me be really transparent about it. Here's how I work with ketamine. This is not how everybody does. And there are different pathways here. And is there something about this is really resonating for you? Or does this feel like you're kind of adjusting your goals to meet my needs as a clinician? Then that's not a great fit for you. So more severe cases sometimes, or folks who I think might need multiple treatments in succession. And then definitely this component of it, are we therapeutically a good fit? And then for me, the other component that I'm looking at is their existing therapy relationship, because I can't maintain these folks long-term. And part of what makes CAP so exciting is it's disruptive for people. It can disrupt for healing potential. It can disrupt in a way that feels really scary for people or destabilizing, especially if there's an underlying trauma component. So I want to make sure people have the right therapeutic support in place. And so that will also influence my decision-making. And then folks who, I specialize in substance abuse. So within our residential environment, there are many clients that we will not advance to CAP because we feel like there's a certain amount of dissociation that they're already kind of navigating in their own internal relationship with themselves. So they can't feel a lot of things. And whether that be because of traumatic dissociation or just like adaptive dissociation, and they use substances to numb. So their relationship with numbing is pretty advanced when it comes to drug effects. And so I'm not comfortable giving someone a tool to further dissociate when there's a baseline level of dissociation that I am already concerned about. And I'm using the term dissociation, and that's tricky because there's a type of dissociation that's therapeutic in ketamine, but I also see that there's a type of dissociation with ketamine that actually predisposes people to problematic use as well. You can really kind of escape yourself in some ways that isn't always therapeutically useful. So I've probably given you way more information than you actually asked for on that one, but this is a topic that's very exciting to me in terms of how we make those decisions. Last thing I will say, I had someone come to me who was interested in more of an off-label application of ketamine. They were actually interested in, they had a binge drinking problem that was pretty problematic. And they had read some things about how ketamine might be helpful. And they were ready to sign up for treatment. And this was an interesting edge for me. And I'm not even 100% sure if I handled it right, but I'll speak about it because it's part of my lived experience. They had not tried any traditional substance use pathways that were covered by their insurance. And we have not figured out how to get CAP covered, especially if we're doing off-label work. In many ways, there's not insurance reimbursement, although some people can reimburse for the initial eval and the prep and maybe some of the integration. But they were ready to invest quite a bit of money in CAP for their binge drinking disorder. And I could see a scenario where I might be interested in exploring that with the client, but what I discovered is they had not exhausted other pathways that are covered by their insurance. So that was one thing that was very concerning for me. And secondly, I just asked about the financial viability of it. And they said that they felt like they really believed this was going to help them and they were willing to mortgage their house to do it. And I ultimately declined them as a client. And I did not feel comfortable with someone taking out a loan to do CAP when they hadn't done the other pathways. That just was a threshold I wasn't willing to kind of step over. I don't know. It could have been really helpful for her. But again, we don't have a ton of research. I mean, there's really interesting research around alcohol use disorder and ketamine, but in clinical trial spaces. For all the reasons I mentioned before, and this piece of like financially overstretching yourself to make this happen, because in many ways it's a fantasy that it's going to move the needle when I know there's a lot more treatment that would need to go into it than just these CAP sessions, right? And how do I know I'm not going to make something worse? So that was a really interesting challenge. And it's getting into conversations of like, can you afford this treatment? And how much of a right do we have to ask those questions, and how much patient autonomy we want to support, and how do we guide people in those decisions? So an interesting scenario for sure.
Definitely. Yeah. I really appreciate you sharing so honestly and providing some insight into the realities of, many complexities arise doing this kind of work.
Mm-hmm.
It's up to practitioners to navigate them responsibly and oftentimes ground in their own intuition about the work they're doing. You mentioned there some of your prior experience and current experience doing addiction treatment work. And I'm curious how running a CAP practice compares to both your experience in practice as well as in leading an addiction treatment center. Are there some differences in pace or team structure?
Mm-hmm.
The regulatory environment, I'm sure there's lots to be said there, as well as client complexity. Just how do these different contexts inform one another? And I suppose specifically your work as a CAP practitioner.
Yeah, that's a great question. It feels very different for me in a residential environment versus an outpatient environment, although there's some threads that cross over for sure. This is maybe a little adjacent to what you're talking about, but it was such an interesting journey bringing CAP into the residential treatment environment, because we run a 12-step friendly program. It's an abstinence-based program. It's a smaller treatment center. We have a max of 11 beds, and we're really known for trauma reprocessing work in our treatment center. And I had been working on the MDMA-assisted therapy trials for many years, and I'd seen kind of the power of how the non-ordinary state effects of a psychedelic compound could really catalyze therapeutic processing and specifically trauma reprocessing. So to be honest, like I don't even know if I would have done an outpatient practice if it wasn't for the rehabilitation setting, because what was happening is in that environment, I was watching different clients come through that got really stuck. And I kept thinking like, ooh, I wonder, I would love to put them in the trial. Or I kept fantasizing about the way that I think about CAP in our environment is because we're doing trauma work there, and people are trying to get better in a residential environment in a very compressed amount of time. And even with clients that are really motivated, they still find themselves fighting their own internal experience. Like, they can't soften a certain protective reflex, or they want it really badly, but it's so hard. Like, I just think the places we're trying to reach inside people that often are at the root of really problematic self-destructive patterns are really well protected for a reason. So, it got really exciting to think about how ketamine could be another resourcing tool for people doing trauma work. And that's how we think about it in our treatment environment, is we don't think about it, as just like a psychopharmacological alternative, which it could be, right? There are some treatment centers that will use ketamine as a treatment-resistant depression intervention, right? And I fantasized about that sometimes in our environment too. But bringing CAP into our treatment program was pretty disruptive, because there were some people that work there that thought all the clients are going to relapse because we're using ketamine in a residential treatment environment, like using a drug that has a drug abuse potential. But for those therapists that were already doing trauma reprocessing work, they were doing EMDR, they were doing IFS, they were doing all these other things, like CAP made a lot of sense to them because it was just another form of trauma reprocessing that was about going within, trusting the client's process, allowing them to pick what emerges, learning how to kind of resource in and out of states of feeling good and then states of challenge. So that made sense. What is very cool about doing CAP in a residential environment that I've seen that's a little different from outpatient CAP is the clients go deeper so much faster because they're in this really tight container and they're already doing trauma reprocessing work with such frequency that they just use the ketamine to go deeper. And because it's, they're getting all this interesting prep along the way, and they need less, they don't need as high doses because their systems are already like kind of know how to work in that way. So it's had a big influence on thinking about ketamine as a catalyst and not just ketamine as the whole intervention, but like how can it amplify an existing therapy modality and then just kind of help people feel better inside to go to places that are typically like really hard to touch into. And that is a very multidisciplinary team that we have the privilege of being able to afford in a residential environment. And then I feel like I'm a little bit more on an island when I do it in outpatient land because it's like solely kind of relying on me and maybe the prescriber that I'm working with. I don't get the benefit of the whole team's perspective on whether or not we think this person could be a good candidate. So I've got this really interesting kind of differentiation of like a full team effect versus just me and maybe the person that I'm working with in outpatient therapy land, and still amazing, wonderful, kind of magical things happen and really challenging things happen in outpatient therapy. But it's just, I feel a lot more pressure because I'm kind of holding a lot more responsibility by myself. Does that answer the question, Kabir?
Definitely. Yeah, that's really valuable context. I appreciate those comparisons. I'm curious to just delve a little bit more into the operational side of things and potentially provide some advice or support for folks that are interested in this, potentially even in a leadership capacity. So are there some operational structures or workflows, team composition, leadership style, anything that kind of fits into the operational dynamic of running a practice that protects that therapeutic frame, but also keeps the business healthy? So it could be, an intake process, the way you schedule, documentation protocol, how you, hire and manage staff and avoid burnout, anything in that kind of broader realm that you feel has been really helpful as you develop your own practice that other people might learn from?
Oh gosh, there's so much there. And I don't know that I'm an expert in any of it, but I'll talk about the one thing I feel like I know the best. And that's that people need, I feel like if you're going to be implementing something like this across folks who, it's one thing to have providers who seek it out, like in your practice, and they're like on board. And then it's another thing if you've got some folks in your organization you're trying to kind of like pull over into becoming CAP affiliates. And I think that matters a lot. I personally love speaking to skeptical people about CAP because there's so many polarizing opinions about ketamine. And I love the idea of dismantling some of those things. And the way that I've found to be able to do that is, again, I'm using kind of trauma as my Trojan horse for everything, but it's like, really impactful, non-ordinary state work in some way is trauma work because we're working on the psyche, the self, the sense of who we are, the story of who we are, what we can tolerate, our belief in our brokenness or our capacity to feel whole, right? Like all of that involves like self-orientation. So what I've found to be very helpful is to find ways to translate ketamine work in ways that trauma therapists can understand, in ways that substance use therapists can understand, in ways that somatic therapists can understand. And you make the thing itself more translational so people understand what it means. That's one thing. I'm just talking about like bringing it into an organization where, say, lots of people have skepticism, right? So that I think is like, how do you preach to the skeptics and how do you build these bridges to really good therapy that ketamine just like sounds like really good therapy? Because that's what I think about it as. It's like this amazing therapeutic catalyst instead of just like expecting that people are going to just be like totally on board with the concept of a psychedelic. I was not a psychonaut. Like I came into this work sideways through like academic research, but I was interested in depth work and emotion focused work. And so once I understood that psychedelics could unlock that, I was like all on board. But like psychedelics themselves like freak me out. Like I'm not great with control and letting go of control. And, so maybe because I came to it that way, I've learned how to talk about it in a way that allows it to be translational to people who would be typically skeptical. And I also talk about the risks. Like, this is not like a one size fit all perfect process, right? That also relates to the idea of, I do think, because is more uncertainty, and we're touching into places inside of people that normally we may not get access to. It's intense. The work is a little more intense as well. And so I think the other thing, just in terms of the well-being of providers, if you're part of a group, if you're going to do this CAP work, I just strongly encourage people not to do it in isolation, because, it's a very different experience to sit with a client who has sobbed for 25 minutes about grieving their mother, when you're not in this therapeutic role of like, like you might find yourself in a regular therapy session. Like, you are impacted differently as well. I mean, I just think that there's a little bit of a softening of the boundaries of being the knowing one, and really you're bearing witness to like the pain and the struggle of just being human. So like, my role as a therapist is incredibly important, but the shared humanity of this work, I think people need really good support in how to navigate that without getting too porous in their boundaries, and without kind of softening things that need to be in place to protect clients and patients. And I think as organizations, or if we're starting into this practice, like, we need good therapeutic support for each other, whether it be working with your own therapist, or whether it be part of a community where you're staffing cases, or within your own organization, talking about the cases that don't go well. Man, that's so valuable, but it does require a different level of vulnerability. But I mean, I guess that's my other like thing is, I think teaching clinicians how to feel better being vulnerable is directly translates to this work, because I mean, in many ways, clients are becoming more vulnerable through CAP work. And so I think that's a really important part of the process, is making sure there's a culture that is willing to talk about what we don't know, and that kind of infuses itself into the work. I think it's very protective for organizations and for clinicians to be talking about where they've been humbled, and where they felt like maybe they failed a client or a patient in the process, or they made a mistake. So I think, to me, I spent a little bit more time thinking about the culture of the organization that brings this in, because it isn't simply like just bringing in another, I don't even have the right words for that. But to me, it feels transformative enough that I feel like we really need to consider the mindset in which it's being rendered. And we need to make sure that there's enough safety. Maybe that's another way to say it, enough safety in the therapeutic relationships that are supporting it, that people have somewhere to go with when it gets challenging. And that's not being kind of held entirely inside. That doesn't have anything to do with documentation or any of the other wonderful things
No,
you're talking about workflow. But like, to me, that's the part that feels like really ethically, clinically, humanly important, is how do we support, the complexity of this work?
Totally. Yeah. I think that, you preempted my next question very well, speaking to some of those essential ethical considerations. I think we have time for one more question from me before we move into Q&A.
Okay.
So I'm curious,
Sure.
for someone engaging in CAP work, what are really the most essential elements of good wraparound care? That's, I think, a term that we talk about in some of our coursework, and find to be an important, orientation towards this work in general. And then the flip side of that question, where do you see common pitfalls for new providers when attempting to provide wraparound care? What are some gaps or oversights that might exist there?
Oh, I could talk about this for a long time, because this is actually true in clinical trial research too, right? You bring people into this clinical trial environment, and they're already working with their own provider. We just had a big debate about this in our lab, actually. Like, do we always reach out to the therapist that they're working out to determine their candidacy for a clinical trial? And that's another question. If you're not working with the client themselves and they come to you for CAP, do you always reach out to their therapist and have a conversation with their therapist that's already treating them about CAP? I'm of the mindset that if I can't have that conversation for a range of reasons, it makes me feel much more cautious about engaging the CAP journey. Because in some ways, I feel like for those of us who have the courage or the craziness to pursue psychedelic work, we do need to be ambassadors in the community for what this work is. And there's a lot of misinformation, and people will have had a lot of negative experiences, maybe from people who've had bad recreational experiences or abuse experiences, or even a ketamine clinic that maybe was willing to treat people that maybe they shouldn't have. I want to be a bridge to the community. So to me, it feels really important to be talking to prescribers. It feels really important to be talking to the treating provider or the therapist that's working with the client. It takes a lot more time. You have to decide whether or not you want to build that into your fee structure. But to me, it feels essential. I also really like talking to their partners and their support people. To me, that feels really important as well, because, you can have this delicate process that you're working on when someone's had a lifelong struggle with something, and their partner's going through their own version of it as well. And then they come home from their CAP session and their partner looks at them and goes, how did it go? Right. Which, like, with all this anticipation and anxiety and pressure for it to work. And if we don't have conversations with their support systems and their family systems, like, it does create a bit of a setup, I think. And then also just like the vital role of integration on the back end of things, right? How do we build a bridge to existing providers in that community and let them know how to recalibrate expectations, or what does it mean to support this person? Not to be dismissive of client or patient autonomy, but to really have transparent conversations, because the integration of this work is not linear, and it can be confusing, and it can look almost like backsliding as people start to feel more or experience more, or maybe have a different perspective on something that they thought they were completely done with something. And then all of a sudden, they had a traumatic childhood and they were like, oh, I've worked on my early childhood stuff. And now all of a sudden it's alive and back with them in a very different way, right? How do we help their support system not just prematurely interpret that as a sign that something has gone wrong? So I think it's incredibly important to be doing the continuation of care thing. It's also very important to, if someone's working with a therapist who has a certain approach and then they do CAP work and they're like, oh, wait, the therapist I was working with doesn't know how to do this kind of work. Like, then where are they going to go when they're done with the CAP sessions? Like, we have to think about sustainability in communities and lower cost integration circles, or community-based, maybe a psychedelic society, or these kind of things. Like, so the last thing we want to do is re-perpetuate silos and patterns of isolation and alienation for people who get up to be a part of this experience, and then they feel totally alone in what they experience, even if it was positive, like there's no one to talk to about it. I think that's, something that we need to be thinking about as a community of providers, and how do we create more networks of support and develop better resources for people that don't just rely on them paying out of pocket and being part of community structures.
Amazing. Yeah, I really appreciate your insight and the vulnerability in both the personal shares you provide and just depth of experience you have. And I'm sure lots of our audience members feel the same. Before moving into the Q&A, I want to remind folks again that if you'd like CE credit, please fill out the survey. I put the link in the chat. You will need to fill that out to receive the CE credit. We'll be sure to grant those within the next week. I also want to remind folks, if this conversation felt resonant and exciting and you'd like the opportunity to engage with Chantelle and learn from her wonderful depth of experience, there will be a upcoming session of our ketamine-assisted psychotherapy specialty course, part of our certificate program, starting, there it is in the chat. It'll be starting in September of this month. I believe the exact date for that start date is on the 16th. It'll be running for a month. For folks who have completed our Essentials of Psychedelic Therapy course or an equivalent course, please feel free to enroll in that. It'll be a wonderful course, lots to learn, building upon this conversation we had with increasing depth and insight. With that, I would love to move towards some of the questions we have from folks. So starting with Isaac, they are a psychology student in Boise, Idaho, where ketamine is the only option available currently, but they plan to move to Colorado to work with psilocybin. They ask, what's one piece of advice on how to get started in this work and stay grounded while building a sustainable career in psychedelic therapy?
Big question. um, well, so as a student, this may be like it's not a sidestep of the question, but I actually think sometimes I don't know what it would be like for me going through grad school right now if we were in the same place with psychedelics, because I think it's such an engaging, exciting area. And I think sometimes, I'm not saying this is the case for you, Isaac, but I think sometimes the enthusiasm for psychedelic work can almost overshadow clinical development, period. And I think a couple of different things. One, seek out clinicians who know how to talk about both sides of this work. So not just people who are talking about how amazing and wonderful and fantastic it can be, but who are talking about the shadow and the complexity and when it goes badly, what it looks like. So that's one thing is if you can keep yourself grounded in cases that go well and cases that don't go well, and really learn how to talk about that and think about that. And I think we need so much more balance in this field. And we need to be willing to talk about when it goes really, when it's really difficult for people or when it's really challenging. And that doesn't mean that it's not necessarily therapeutic. So that's one piece of the groundedness piece. And then the other piece is just like developing really solid clinical skills that don't rely necessarily on psychedelic work. Because in many ways, like I have never felt more challenged therapeutically as a clinician at this stage in my I know I would not feel challenged the way that I do now. And there have been situations in psychedelic work that I think all the time where I go, oh my God, like, I don't know if I know what to do, like all the time. and I'm so grateful I have a lot of years of clinical experience because I rely on my clinical instincts a lot. And so I would say continue to get the exposure to diagnostic, severity and working with people across the spectrum, because I think it really does help your gut identify people who may not be candidates. And so, spend your time in non-psychedelic spaces as well as psychedelic spaces is one of the things that I think is really important. And I appreciate the question.
Awesome. Yeah. For folks who are watching, now is the time for any additional questions. While we wait to see if anyone else has one, I actually have a question of my own. When you were discussing managing expectations and communications with clients, that jumped out to me, and I can really appreciate the way disappointment factors into the psychedelic experience for so many people and can dictate so much of the integration component of CAP. I'm curious if you could share some more potentially about how you work with clients to help them understand the variability of a psychedelic experience and the real potential for disappointment and way you can work with the expectations people are bringing to the table. If there's maybe a little more you could say about that, I definitely think that's an important consideration for new practitioners.
Yeah, thank you for that. Well, one way maybe to think about it is how do we differentiate intentions from expectations? I think that's an important nexus point. I was just talking to someone about this the other day. Because intentions are confusing. People say set an intention. And in some ways, an intention can sound like an expectation. But one thing I love to really remind people about is that when they go into a psychedelic session, in some ways, the thing that might make it the most impactful is the part of it that they can't predict. So it's like in many ways, part of why one theory of why psychedelics are so impactful is they're taking us off the grid of prediction. They're taking us off of the well-worn pathways of orienting to ourselves and to the world and to others, or even to the condition that we're navigating. And they're making us rethink or quite literally connecting parts of the brain that don't normally talk to one another. So in some ways, you always want to hold gently this idea that you want something to happen in the session, because the part of you that's coming up with that idea is also part of you that's probably really stuck. So in many ways, you kind of want to soften back that agenda or that kind of expectation, because what can happen if you get too grippy on what you think needs to happen, it's like you literally, like, the energy that it takes to be focusing on what isn't happening can literally squash out anything new that could have happened. And so that's another way that I talk with people about it, is like, if you're spending all your time in conflict about what you think needs to happen, then you're not listening to the quiet voice in the background that's actually telling you something new. So how do we soften that and kind of make room for something different? And still, you can feel the sadness of what didn't happen. Like, lean into the feeling of what didn't happen instead of the expectation of what you think needs to happen. And then that will make more space for something new potentially. So I think about intentions as a more helpful way to think about an intention is, how can we together co-create a way you would like to be in the session instead of an outcome that you expect. So if you're the type of person
Amazing.
that never asks for help, how can I ask for help in the session? Because that's not something I would normally ever really do. Or how can I soften my idea of what needs to happen? Or how can I be kinder to myself when things get challenging, right? Like, that's a different way of thinking about intention.
Totally. I love that relational perspective and the
Yeah.
co-creation of that therapeutic
Yeah.
container. Very valuable. We have time for one final question from
Mm-hmm.
Nathaniel here in the chat.
Mm-hmm.
They are a MAPS trained clinician working with ketamine in private practice in an infusion clinic.
Huh.
They're the only clinician and having trouble navigating the isolation. How do you manage these types of hurdles? What advice might you have?
Well, congratulations on having such an important role as the only clinician in the infusion clinic, working therapeutically with clients, is, if I'm understanding that. Uh, Gosh, I'm lucky because I have a lot of people in my community that I've accrued over time, but like taking courses and building connections through those courses and reaching out to people that you've been in training with, even if they're not in your same state, and just setting up informal consultation groups or something like that, I think can be really valuable. Invaluable, I should say. The other thing is, I don't know, I find podcasts really helpful. They make me feel less alone. I feel like I learn more about other people. I feel like I can be in dialogue with people who are like-minded with me without being present with them, by seeking out podcasts or webinars, or, it's like, it helps with that sense of alienation, isolation. There's so much information out there. So I think there are ways to do it. It would be so nice if it was like in your hometown, part of your group of providers. Local psychedelic societies can be another way to build relationships with people who are kind of like thinking in like-minded ways. I do think there's avenues, but I'm not in that position, so I have a lot of compassion for your situation. And the fact that you're on here is a great sign, because it means you're reaching out and you're looking at other avenues for learning from other people and sharing your experience.
Wonderful. Well, that brings us about to time. I really appreciate your input and wisdom. Everything you've shared with us is, I'm sure, going to be very helpful for up and coming practitioners, experienced practitioners, folks moving into leadership roles, anyone interested in the sustainability of a CAP practice. Again, thank you so much for joining us. And for folks interested in learning with Chantelle in the future, please be sure to check out our courses, our upcoming opportunities. As mentioned, folks who join a Fluence course have access to our listserv, a large community of practice, wonderful way to connect with folks within our own network if that's of interest. Thank you all so much for joining. We very much appreciate it and look forward to the next webinar next month.
Yeah, thanks for signing on, and thanks for having me. It's lovely talking with you.